to tell you about something that happened a couple of weeks ago. I was watching TV and saw a good couple of commercials, and they were always asking about money or wanting money. You know the kind of fundraising commercials I'm talking about. You know, the ones that usually focus on one area of the world, but sadly seem to generalize them and make it one country. You know exactly the ones I'm talking about. The ones that ask for more money for shelter, more money for food, more money for refugees. Rightful causes, absolutely incredibly important. But one thing we're not seeing is, I certainly didn't see it, is can you give us some more money for a health worker? Can you give us more money to train a healthcare worker? And as I thought about this more, I started thinking about this number, 7.2 million. What do you think that is? It is actually the number of people who have potentially prematurely died due to air pollution. You know, and it's certainly the number of mince pies that were left by children on Christmas Eve in the UK last year on Christmas Eve. But what it actually is, and this is the hard thing, it's actually the global shortfall of health workers we have worldwide today. You know, that's greater than the population of Ireland, but less than the number of subscribers to Netflix over the last quarter. Yet everyone talks about Netflix, you know, but does Netflix save lives? Does it improve the quality of life for many people who suffer from medical ailments around the world? Let me throw another number at you, 12.9 million. That's what the shortfall is going to be by the year 2035. It's not getting better, it's getting worse. And if we think about 2035, there's loads of other people talking about 2035, basically saying, and I'll give you an example, Boeing and Airbus. They're already talking about, yeah, by the year 2035, we're going to have a shortfall of 600,000 pilots. Ooh, how dramatic is that? You know, it's like, imagine the outcries, oh, I can't travel, can't go on holiday, can't go to Cancun and act like a complete idiot. But, you know, but when we think about it from a health workforce point of view, this is the crisis we face. So, to put it into even more context, we currently have 1 billion people around the world that don't have access to adequate healthcare or even afford adequate healthcare. We also know that 50% of the world currently lives in rural areas. So when we looked at these rural areas, we can tell you something about the health workforce. They are served by only 38% of the total nursing workforce in the world today. They are only served by 24% of the total physician workforce worldwide. So who can't tell me here we're not in a crisis? We're in a massive health workforce crisis right now. So we've got to start thinking about a term that's been bandied around quite a bit. You may have heard of it. It's called universal health coverage. And what that means is that every person, every community in the world has the right to promotive, preventative, curative, rehabilitative, and palliative services that are of a decent quality but do not place a financial burden on themselves. But the key point of universal health coverage, a key dimension, is that we need to have strong health systems, and we need to have an adequate number of health workforce people in individuals and communities. And we don't obviously have that. You just saw the numbers. So what we did over a 2-year period, we looked at this a lot more closely. And what we can absolutely tell you for sure is that 90% of all healthcare needs can be dealt with at the primary care level, and only 10% can be dealt with at the specialist level. So therefore, if we're going to make sure that we get this health workforce crisis right and get health access correct, we've got to focus on primary healthcare education, okay, rather than specialist healthcare education. And when we looked at it even further, we were able to say that actually there's also factors such as internal and external migration. And I'll give you an example of Senegal and Dakar. Right there, right now, in the Dakar region, they only have 23% of the population, but over 60% of the physicians work there. Doesn't make sense. So even if we were to get training models right, this internal and external migration factor is obviously playing a key role. But we're obviously not getting the training models right because we're not training the right number of healthcare workers. even if we were able to, what we were able to see where models were successful, unfortunately right now, health workers don't even have the time. They don't have the time to take out in terms of their workplace, or even have the money to afford to get someone to replace them when they do get trained, or when they do further their education. So what are we going to do? Are we going to build new medical schools, new facilities around the world, new nursing schools, new schools of physiotherapy? Unlikely. We're not going to be able to do it rapidly enough to actually address this crisis. But what we can do is think about what we have in every corner, and that's innovation and technology. So during this research, I like thinking about one particular quote that came out from one of the interviewees, which was, "The mobile phone is the most potent virus the world has ever faced." And it is. It's an epidemiologist's nightmare. But because of that, and because we spoke to lots of leaders in healthcare, the WHO, PAHO, Wonka, and also did a deep dive into the literature, what we were able to see certainly was insight for a road forward. And this road forward has to incorporate innovation and technology, but it also has to incorporate interprofessionalism. And therefore, we're now seeing the solution that can help us recruit, retain, and retrain health workers, and therefore address the needs that we need to. So we decided to look at this further, and what we were able to say is that information communication technologies can work in 6 ways. And these 6 ways are as follows. 1, they do improve health workforce capacity. 2, they do allow us to recruit and retrain, and we saw this in geographies all over the world. And 3, they allow for collaborative learning, and that's really important. 4, cost saving, as I mentioned, but also allowing for context-driven training. And that is so important in medical education. The amount of stuff you get sent to you, even in areas we looked at sub-Saharan Africa, we saw trainees that were getting taught about frostbite. And you're going, really? It's got to be way more context-specific. But also these technologies then allow us to actually think about the dynamics of learning and think about information exchange. Interestingly, on top of that, which is something really important to me as well, is mentoring. I would refer it to now as e-mentoring. We were able to see mechanisms and examples where what we can do through education that's driven by technology is that actually we can build bridges between different professions, not just in terms of idea exchange, but allowing them to access experts that they wouldn't have locally, but also mentors that can help them address personal and professional issues that they're facing every day. Right now, healthcare workers in certain geographies of the world are under incredible stress. And if they're able to address these issues via an e-mentoring mechanism, and this could be simple, it doesn't have to be the new app that's come out from around the corner. Simple video conferencing. Skype's been around for decades. Just simple things like that, but creating an organizational structure behind that will help with e-mentoring. These technologies can also help us with the dynamics of learning. And some of us in education like to ideally all be working in what we call communities of practice, where we have shared goals and we all come from similar professions. But these communities of practice can now change. And now what I would be referring to them, and certainly our research refers to them now as virtual communities of practice. And again, it doesn't have to be novel tech. It could be something quite simple. And we saw this with examples, for example, WhatsApp. We're all on WhatsApp groups. And I will honestly tell you, 99% of the stuff that you currently see in those groups is rubbish. But if it's curated right, if it's administrated correctly, you can have a virtual community of practice where ideas are exchanged, and you get an environment that's conducive to experimentation, simulation, idea exchange, community building, and reflection. So what am I going to say to you guys based on this research in terms of recommendations going forward if we're going to address this crisis and we're going to start using technologies further? The first and most important recommendation, and this came out through a big scoping review we did on interprofessional learning and technology, is that interprofessional education is key. Let me refer to it as IPE e-learning for now. And what we were able to see, we looked at over 1,000 papers. We looked at studies that did only 1 hour of study all the way to 2 years of study. We looked at studies that only had 28 students all the way up to 1,800 students. And what we're able to tell you is that IPE learning does overcome geographic barriers. Okay? It does allow for contextualized learning. It does allow for flexibility of engagement, which is very important. And it is cost saving. We're able to see that after year one, technology-driven education can drive costs down by over 50%. So when people say, oh, the initial investment's too high, no, it can actually be much more cost-saving long-term. But then we've also got to recommend that the fact that all this education has to be standardized and accredited. And this is what we saw from all the interviews that we took part in. We have to make sure it's context-specific, but we've got to avoid what we call technology redundancy. And what I mean by that is coming back to the whole new app idea, the new technology idea. That's great for a few percentage, small people in the world, but it's not for everyone. We still have a divide between zip disks and USB. We still have a divide between the most basic Android phones to the most recent iPhone. So we have to be very careful about this digital divide. Okay? So the final point and recommendation we put forward throughout this research is probably for me the most important one. We've got to recognize the interdependence of primary healthcare workers and the new dynamics of the primary healthcare team, which means it's no longer about the doctor. It's no longer just about the doctor and the nurse. It's the doctor, nurse, allied health professional, community health worker, and most importantly of all, what allows us to build a bridge via technology to them is the patient. We can now develop these communities of practice virtually, bringing the patient in, feeding into our educational mechanisms. Therefore, if we're going to achieve universal health coverage, we've got to think about the dynamics of primary healthcare education and how innovation and technology can drive it. So what I want to ask you is think about looking at what you have in your hands, looking at the person next to you, looking at the person who might be the person you'll be working with now or in the future, or even asking the person in the office who you just might not like, how can we learn together? How can we collaborate together? How can we use the power of technology to drive this education forward? Thank you.